Hey guys, so we didn't get a chance much to talk about the endocrine control of fuel metabolism. We're still going to have a lecture next week on the endocrine control of metabolism, and we are really talking here about the pancreatic hormones. We're going to focus more about them. I mean, there are other hormones that are involved in metabolism. For example, thyroid hormone T3 is, as you know, increases the basal metabolic rate and does other things. Cortisol is associated with carbohydrate metabolism, lipid metabolism, protein metabolism. Growth hormone was also associated with protein metabolism, carbohydrate metabolism. So I don't want you to think that the only 2 or 3 hormones that are associated with the fuel metabolism are the pancreatic hormone. That is not true. Even testosterone is associated with fuel metabolism. So I want you to have this title with a little bit of a grain of salt, that control of fuel metabolism is not only restricted to the gastrointestinal tract, is not only restricted to the hormones that are secreted by the pancreas or hormones that are secreted by the rest of the GI tract. So just keep that in mind. What I'm going to try to do is to review first certain terms that we have used before when it came to the adrenal hormones, when it came to the thyroid hormone. And these are metabolic terms, metabolic terminologies. They are like, what do you call making sugar? Or what do you call breaking up glycogen? And these are things that we have gone through before, but it's very nice now that we put them in perspective. We start to recognize the metabolism as, okay, you are building things, and if you remember from Biology 101 that you had sometime in middle school, there is something called anabolism, and then there is something called catabolism, anabolic reaction. Catabolic reactions, anabolic reactions, you're building things, you're building proteins, you're building triglycerides, you're building glycogen, and in catabolic reactions, then you're harvesting that energy. So you're breaking triglycerides, you're liberating fatty acids, and you may break those fatty acids and generate energy, and maybe that will generate to you some ketone bodies, and we're going to talk about the ketone bodies. You break up proteins and then liberate amino acids. What are you going to do with amino acids? Are you going to deaminate them and use it for energy? Use it to burn the carbon bonds and liberate some energy for you? And or what are you going to do? Are you going to use those amino acids to heal an inflammation or a stressful situation your body has? So we're going to go through those terms together, and whether it's building terms or breaking up terms. And then we're going to focus primarily on the pancreatic hormones in this very short lecture. And the pancreatic hormones we're going to be focused on are insulin on one side, and the anti-insulin or the glucagon on the other side, in addition to other hormones that we're going to just mention. Okay, so I told you earlier that there is anabolism or anabolic reactions where you're building things, catabolic reactions where you're breaking up things. There's not much worth time here investing in this slide. This is ABC biology, so we're going to keep moving on. But here are some terms for you. Glycogenesis, you're making glycogen. Glycogenolysis, you're breaking glycogen. Gluconeogenesis, you're making sugar from non-sugar. So whether it is from proteins that you are deaminating the proteins and you're making sugar, or you're breaking triglycerides, and just please remember that only the glycerol part of the triglycerides can be used to make sugar. The fatty acids, you can never convert fatty acids directly to be sugars. Just keep that in mind. If you are building proteins, So there is a building up of amino acids, or are you breaking up the proteins and liberating amino acids? Are you making fat? That's lipogenesis. And or are you breaking fat? That's lipolysis. So essentially it's the story like that. If you have a lot of energy that you have just consumed, you just finished lunch, so it's your goal now not to break things, but to build things, to hide things, right? And so you start to build triglycerides, you start to build glycogen, you start to build proteins. But when you're starving, you can't be in the process of building. And starving doesn't mean that you're in a stranded island for, 10 weeks. Starving just means few hours after the meal. Your body now requires energy. We call that the post-absorptive state. And so now you have to liberate that energy. Where do you get to the energy? Well, from your storages. What storages? Well, when it comes to carbs, you go to your glycogen molecules. When it comes to fat and energy, you go to the triglycerides. When it comes to amino acids, you liberate that from the proteins. And there is interconversion between those, as I said earlier, that sugar can become triglycerides. Triglycerides can liberate energy in form of fatty acids, and also can liberate you the glycerol that can be used either as energy or to make glucose molecules. Amino acids can be used as energy. So there is an interconversion between the three different forms that you have of energy. So just keep an open mind. As I told you in the lecture, there is unfortunately mislabeling, a lot of mislabeling nowadays of, you buy a bag of candy and it's 100% sugar essentially, and it says on it 0 fat. Everyone is like, yeah, great, that doesn't have any fat in it. Well, your body is going to make the fat. Just because you're taking a lot of energy, you don't anticipate that this energy will be stored as glycogen. Well, there is a very limited storage space for glycogen. The liver is not going to get any bigger than it is. Your muscles have limited capacity for storing new glycogen. So it ends up that the extra sugar that you're consuming, the extra carbohydrates that you're consuming, will end up to be fat, right? So just keep an open mind when you see something saying 0 cholesterol or 0 fat, and just think that your own body also generates these molecules. So there is an interconversion between these molecules, okay? So I'm going to skip this review slide here, and we'll just go in a little bit to the pancreatic hormones. Like I said earlier, excess glucose can be either stored as glycogen, but really we have limited capacity, so the rest will be triglycerides. And fatty acids, excess fatty acids will become incorporated as triglycerides. Amino acids, you're not gonna, even if you're eating 100% proteins, you will start to build fat, and the reason for that is that you're not gonna build more proteins than your body needs, than the demands of your body. And so the rest of the proteins that you keep munching on are not going to be muscles. Unless you're exercising and stuff like that, then yeah, some of that will become a muscle mass. But if you're not doing any exercise, and all that extra amount of amino acids and proteins, all of that will be converted into fat, right? And so there is, once again and again and again, I'm going to say that, there is an interconversion between those molecules. Some people say, oh, I'm going to live on high protein diet, and therefore I'm never going to gain any weight because I'm not taking any carbs. That's not true. You will gain a lot of weight. I'm noticing more and more that my voice is still raspy from being sick, so I hope you don't mind that. So anyways, we did cover that, the interconversion and the synthesis and the breakdown. I want you to be aware of this fact, however, that the brain utilizes only glucose for the first 48 hours of starvation. So it doesn't have the enzymes yet to start utilizing ketone bodies. And the liver after 48 hours, we'll start to develop those ketone bodies, which are generated from the failure of the Krebs cycle to be completed. And then you have a lot of fatty acids being incorporated there in the Krebs cycle. Acetyl coenzyme A will start breaking up, giving you acetoacetic acid and beta hydroxybutyric acid. And so all of these guys will be what we call the ketone bodies. And they're not really bad for you unless they are in excess. When they are in excess, then your pH of the blood will become acidic. And you don't want that, because as the pH become acidic, then there will be a lot of metabolic problems that will be hindered because the pH is not favorable at these conditions. So the ketone bodies is not like a really nasty word. The ketone bodies is a physiological product that comes from the breakup of the fat, and these are good for the brain and to start utilizing them in the absence of sugar. But however, before those 48 hours, you have to realize the fact that your body will shut down in the muscles and then shut down in the lipids, in the adipose tissue, will shut down the glucose uptake. And the reason for that is what you want to do is you spare the sugar to the brain. We call that glucose sparing effect, which is very important effect, especially when you come to something like cortisol effect. The cortisol effect spares the glucose to be used by the brain. Why is that? Because we know that the brain cannot use for the first 48 hours anything but sugar, whereas the muscles can use any kind of energy, can use fatty acids, and they're okay with that. But the brain needs the sugar. So what they do, what the body does, shuts down the glucose uptake by the rest of the big mass, muscles and adipose tissue, and spare the glucose for the brain, right? So keep that in mind, and especially when it comes to hyperglycemic hormones such as cortisol, which liberates glucose and at the same time allows the liberated glucose to be diverted to the important organs like the brain, like the kidneys, but not necessarily the muscles. You don't really care about the muscles at that point, because the muscles can use any alternative source of energy. Sounds good? Okay. So just keep in mind this fact about the brain and its sugar demands. So as I told you earlier, in metabolism you have two stages in metabolism. One of them is an absorptive state. In absorptive state, half an hour or an hour after a meal, your body is loaded, or not an hour after a meal because it will take you some time to digest. I'll give you that. But half an hour after you absorb a meal, right? So you have all kind of amino acids in your blood. You have all kind of fatty acids in your blood. You have all kind of glucose molecules in the blood. And in this absorptive state, it's your job to hide these molecules. You can't have too elevated glucose. It will start to show up in the urine. You have to start to put it away in safekeeping. And you have to open the gates. And that's what insulin really does. It opens the gates to start hiding those molecules. But also in addition, you start building up those molecules into something bigger. You do anabolic reactions. Why? Because you have excess of those building units. So you start to make glycogen. You start to make proteins. You start to make lipids. And that's in the absorptive state. In the post-absorptive state, few hours after a meal, now you're not absorbing anything. Your body has already hid your nutritional components. There are no fatty acids, not much. I mean, there is limitation, but there is less fatty acids in your bloodstream. There is less glucose in the post-absorptive state. There is less amino acids, obviously, because you just hid them and utilized them. So now, in the post-absorptive state, you want the post-absorptive hormones, like cortisol, like glucagon, that will start to liberate, like growth hormone, that will start to liberate some of that energy. Why is that? Because you don't have energy. You're not eating and munching all the time. You're eating every, 6 hours. Some people like to snack all the time, which, by the way, I'm guilty of that. But it's not, but it's not good for your health. You're supposed to eat regularly. Maybe in the middle you can have a little small snack, but not all the time. Not like your hand is tied to the potato chips that you're eating 24/7, because you will never have the time to go back to the storage and say, okay, liberate to me some of the energy, because you are all the time will be in the absorptive state and you will never get into the post-absorptive state. So just keep that in mind as we talk specifically about insulin and about glucagon. Sounds good? Okay. So there are key organs here. The liver is the primary place for a lot of the metabolic reactions. Adipose tissue, that is where most of the energy can be stored. Muscles, amino acids can be stored, but there is limitation. You're not going to be building more muscle mass than you need. But it's also a sugar user. It has limited storage for glycogen. The bigger storage for glycogen obviously is the liver. Brain, we said earlier that it cannot store energy. It needs constant demand of energy, and the energy in the first 48 hours, as you remember, has to be glucose, and then later on that energy can be ketone bodies, right? Okay, so these are just key tissues here in the metabolic states that we need to consider. Okay, so we've covered that already. Glycolysis give you glucose. Actually, glycogenolysis will give you glucose, but glycolysis is the breaking up of sugar itself. Lipolysis, you're breaking the lipid to give you glycerol, and also you get fatty acids. And fatty acid metabolism in the liver, you get the ketone bodies, beta-hydroxybutyric acid, acetoacetic acid. Both of them are acidic, and the accumulation of those acidic molecules can result in ketoacidosis. Protein breaking up, if you need the energy, then you are releasing amino acids, and that can be utilized as glucose in a process of deamination, or you can just burn them straight in your Krebs cycle or citric acid cycle. Okay, so now to the pancreatic hormones. That's really the main goal of this lecture, is to talk about the pancreatic hormones. So we have in the pancreas, there is exocrine function, which is associated with the digestive functions of your pancreas, your lipase activity, breaking up fat that you ate, your lactase and amylase, your protease activities, all of these things, bicarbonate that it's secreting to neutralize the acidity of the stomach, all of these things are exocrine function. But in addition to that, we also have endocrine functions, which are limited to islands inside your pancreas, and we call these the islets of Langerhans. The gentleman who discovered them, his name was Langerhans. And we have the beta cells, alpha cells, delta cells, F cells, and we also have what we call the epsilon cells, which is not on this list. Beta cells, they're associated with secretion of insulin, mainly insulin. Alpha cells, they will be associated with secretion of glucagon. If you don't remember, glucagon has the letter A, and alpha has also the letter A. So alpha, glucagon, beta will be insulin. The delta cells will be the somatostatin, and your your F cells will give you pancreatic peptides. We don't necessarily know what the pancreatic peptides do, and there is a debate, scientific debate on them, so we're not going to cover them much. We're going to focus more on insulin and glucagon. Somatostatin has inhibitory role that it can play on the secretion of the pancreas itself, but also it plays an inhibitory role on the absorption of nutrients. And that's kind of a feedback to tell the intestine to slow down a little bit. And the same thing they think that also the pancreatic peptides do is slowing down the absorption, because wait a second, we can't handle all that absorption. So there's some kind of negative feedback that's going between the intestine and your pancreas. And whether it's the delta cells, your somatostatin, by the way, the somatostatin in the hypothalamus is your growth hormone inhibitory hormone, whereas here it has completely different roles. So you see how hormones, sort of like the dopamine in the basal ganglia, or the basal nuclei rather, it was associated with motor functions in your limbic system. It was associated with depression and like antidepressive, and in the pituitary it was associated with prolactin secretion. So it's an inhibitory for prolactin secretion. So you see, hormones can act at different organs, at different targets, and produce to you completely different results. So for example here, the somatostatin. Okay. So here are the islets of the Langerhans, and I said there are the alpha, the beta, and the D cells, and the FF cells, or the F cells do not show here, and the epsilon cells as well. Okay, good. So the somatostatin, as I said, they are secreted from the delta cells. They inhibit the absorption of nutrients, tell the intestine to slow down a little bit. They may have a role in reducing the levels of insulin and glucagon, and but there are other things that we still are working on it scientifically, and we're trying to figure out what it does. By the way, the somatostatin is also secreted by the gastrointestinal lining. Just keep that as a fun fact, not that it's important for us at the moment, because we're really dealing with the pancreas. Okay, sounds good. So we're gonna start with insulin. We all know that the lack of insulin will result in diabetes, but also the lack of the receptors for insulin will cause diabetes, because we call that insulin resistant diabetes. That means it's the kind of diabetes you cannot treat with insulin, because obviously you don't have the receptors for insulin. So it's an anabolic hormone which is secreted in the absorptive state. Let's go back again. Absorptive state, what is that? You just finished eating, and now you're absorbing all these molecules into your blood. So you have tons of sugar, you have tons of amino acids, tons of fatty acids, and now it's time to hide and build. These are the keywords: hide and build. So what does it do? Builds glycogen, hides the glucose, hides the amino acids. And what does it do with the amino acids? Build proteins, build fat, build glycogen, build something with it. It lowers the sugar level, it lowers the amino acids level, it lowers the triglycerides level. Make sense? It is important for the growth, because without your ability to utilize the sugar, then your growth is going to be impeded. And by the way, insulin, when we get to the regulation of appetite, you will realize that insulin, when it's secreted, which is secreted in the absorptive state, insulin is important in inhibiting the brain centers to tell you, okay, you ate enough, because now you have the insulin, right? So when we get to the regulation of the appetite, you will realize that insulin is also playing a role there at your hypothalamus. Make sense? Okay. So the secretion of insulin will be more during the absorptive state, obviously, because it's an anabolic hormone. It is associated with hiding and building. Again, hiding and building. Keep that in mind. Stimulation for its secretion. You just ate, so you have high amino acids, high glucose. Those are the stimulants for the secretion of the insulin. But in addition to that, we have other secretion, the other stimulants that will stimulate the production of insulin. There are stimulants coming from the intestine. We call them incretins. And those incretins, like GIP and GLP-1, these are going to be very important, because they stimulate your insulin production, as you will see, to give you heads up, right? Just keep that in mind now. We're going to talk about the incretins later on. Additional stimulant for the insulin secretion will be the parasympathetic stimulation of the pancreas. The parasympathetic stimulation of the pancreas will also increase the insulin secretion. Sounds good? Excellent. So what does it do? Like I said, hides and builds, hides and builds, hides amino acids, hides sugar, builds glycogen, builds protein, builds triglycerides. Sounds good? It's also associated with growth. It's also associated with inhibition of appetite, right? So keep that in mind. We have, in order for us to understand and appreciate the function of insulin, we need to appreciate the fact that glucose is a water-soluble molecule, and it cannot enter to the cells without a transport mechanism or a facilitated transport, as we learned in Bio 101, also in Chapter 3 when we talked about cell transport. And the glucose transporters we have, they're called GLUT. And we have several types, GLUT1, GLUT2, GLUT3, GLUT4. I'm going to focus more on GLUT4. We have 14 different types. So in GLUT1, it's in the blood-brain barrier, and GLUT2 in the kidney and intestine, also in the pancreas. GLUT4 is my main concern here, because GLUT4 is the only one that is regulated by insulin. It's the only one that is regulated by the insulin, and it's present in the muscle bulk and in the adipose tissue. Remember that. GLUT4 is the only one that is regulated by insulin, and we're going to see how it's regulated in just a little bit. Sounds good? Okay. So what does insulin do with the fat? Well, it enhances the fatty acid entry to the adipose tissue. It increases the GLUT4 transporters. Remember, GLUT4 is the only one that's regulated by insulin. And so what happens when you increase GLUT4 to the adipose tissue? Now the adipose tissue will take more sugar. What is it going to do with that sugar? Obviously, the adipose tissue is not going to make glycogen out of it. It's going to make triglyceride out of it. Right, so you're stimulating the triglyceride synthesis. You're inhibiting the enzymes that are associated with, this is a spelling here, this is an I. I'm sorry about that. I don't know how that happened. It inhibits lipolysis. It inhibits the breakup of fat. Sounds good? Okay. Why does it inhibit the breakup of fat? Well, you just ate. Why would you break up fat at this point, right? Okay. Good. All right. On proteins, when you're building proteins, you just ate, you're building proteins. Are you going to degrade amino acids and liberate sugar? Why should you? You just ate. And so I'm not going to make gluconeogenesis. I'm not going to enhance my proteolytic enzymes. In matter of fact, I'm going to enhance the uptake of the cells to amino acids. I'm going to enhance the protein synthesis enzymes. I'm going to suppress the protein breakdown enzymes. I'm going to suppress the gluconeogenesis enzyme because I have tons of sugar. I don't really care about gluconeogenesis now. Sounds good? Okay. Excellent. So as I told you earlier, the main stimulant for insulin is sugar. Well, how does that work? Well, sugar comes into the pancreas and utilizes GLUT2. And GLUT2, remember, GLUT2 was not insulin dependent. If you remember, the insulin dependent glucose transport protein was, anyone? GLUT4, right? So in the pancreas here, we have GLUT2, so the glucose comes in, no problem. The glucose will be oxidized, and it's going to give you ATP. It just happens inside the cells that you have potassium channels that will be ATP sensitive. If you have a lot of ATP, it will shut down that potassium channel. It will shut down the potassium channel. When you shut down the potassium channel, it will cause the cells to be partially depolarized. Cells will be partially depolarized. Depolarizing the cells will allow the calcium to start getting in by voltage-gated calcium channels, and that calcium will start the exocytosis of your insulin. So in other words, when you're eating sugars, right, you're not gonna make insulin from scratch, because obviously this will take like 10 hours. All what you will do, you will exocytose pre-existing vesicles that have insulin in them. How does that work? Insulin gets in the cells, sugar gets in the cell, it will start burning up, giving you ATP. ATP molecules the accumulation of ATP will shut down a potassium channel that is dependent on ATP. You cause partial depolarization of the cells. The depolarization is enough to activate voltage-gated calcium channels. The voltage-gated calcium channels will kick in calcium. The calcium that comes in will enhance the exocytosis of those secretory vesicles that have the insulin in them. Sounds good? Excellent. we need to remember that mechanism for enhancing the secretion of glucose, and this is pretty much what we talked about earlier, the regulators other than sugar. So increased amino acids will increase the insulin. There are very important peptides. They act as hormones. They talk with the pancreas. They're coming from the intestinal lining, from the duodenum and the distal intestine, and those cells will secrete to you what things that I told you earlier called incretins, and those guys will stimulate the insulin secretion. Two of the incretins are mentioned here: glucose-dependent insulinotropic peptide, GIP for short, and glucagon-like peptide 1 is another one. Okay? Why do we have them? Well, imagine this situation. You just ate, right? And so your intestine now is subjected to a high load of glucose, right? This glucose, sooner or later, is going to be heading towards the pancreas and towards your bloodstream. Wouldn't it be great if the intestine gives heads up to the pancreas, telling the pancreas, hey pancreas, we are having tons of sugar here that is coming your way. Maybe you should start secreting already the insulin to have, an advantage, time advantage. So by the time all that sugar rushes into your blood, you're not going to be like, oh my God, what am I supposed to do now? Make sense? So the GIP and the GLP, they function in giving you heads up. So your pancreas start already making or secreting more insulin. And those are the GIP and the GLP that we also discussed during lecture. Parasympathetic stimulation will increase your insulin secretion. Sympathetic stimulation is going to inhibit the insulin secretion. And some of you are like, why would it do that? Well, imagine you're in a fight or you require the energy, right? Because you are in a fight or flight situation with the sympathetic nervous system. Is it really a good idea for you to make insulin at that stage? Because what insulin does, let's review what insulin does. It hides the sugar. It builds stuff. You're not in a situation where you want to build stuff. You are in a situation where you want to break up molecules and release some energy. So, in this case, you want to inhibit the insulin rather than stimulating the insulin production. Making sense? Good. Okay, this is just some kind of a review slide for what we just discussed. There are problems, of course, that can be associated with insulin diabetes. We have type 1 diabetes. You don't have insulin. We don't have type 2, and sometimes you're born with it. Type 2 diabetes, then it's either the insulin you're secreting is not enough or the receptors are not sensitive enough for the insulin secretion. Treatment, you can treat insulin by limiting your sugar intake, by exercising. Why exercising? Because check this out. You know GLUT4? We said that the GLUT4 is in the muscles and also in the adipose tissue. I told you that insulin increases GLUT4. You know what else increases GLUT4 in the muscles? Exercise. So when you exercise, you bypass the importance of insulin on the muscles. That's why we advise diabetic patients to walk and exercise, because not only that will help them physically and reduce their cholesterol level and all that, but also will open up the GLUT4 transporters in the muscles, and which will help you uptake some of that sugar. Make sense? Good. And so other mechanism that you can treat patients with limited insulin, like type 2 diabetes, and you may have heard that in like ads and stuff where you where you are not giving insulin, but instead you're giving a drug that will affect this channel. You remember, blocking this channel by ATP will result in the secretion of insulin. Remember that potassium channel that's ATP dependent that we talked about? But there are a group of drugs. There is a group of drugs that is called sulfonylurea drugs. And those will inhibit particularly this channel. And therefore, they're not going to act as insulin. They're not insulin, but they will enhance the secretion of insulin. So this is one way to treat diabetes. There are many ways of treating diabetes. You can, in cases, of course, obviously, where insulin is a must, you give insulin, but you can also enhance the making of insulin, like with a sulfonylurea. You can block glucagon. As you will learn in a little bit, glucagon is anti-insulin, so that will increase the sensitivity of your body to insulin. There is a new drug now, which I think is ridiculous, Invokana, which blocks the reabsorption of sugar from your kidney, resulting in the loss of sugar, which is not really a good idea, in my opinion, because you will end up with dehydration, you will end up with ketoacidosis, you will end up with infection in the urinary tract because of all the sugar that you are throwing in the urine. So I'm not sure if it's a really good idea, Invokana is, but there are anyways different ways of regulating the diabetes. Okay, so in diabetes, when you have insulin insufficiency, if you think about it, the main problem here is you have too much sugar and your body cannot utilize that sugar. So your body will utilize fat, right? And when you utilize fat, then there is ketosis, and that can result in metabolic acidosis, which is, if untreated, it can result in diabetic coma. Also, metabolic ketoacidosis can result in hyperkalemia, as we studied in our urinary system and regulation of pH. You're not building amino acids. Remember, the insulin was associated with uptake of amino acids and building of proteins. So you will see that there is a problem in growth, especially in children. You're breaking the amino acids and you're making sugar out of them because you're unable to utilize the amino acids to make proteins, and that increases the urea output. You are breaking up more proteins. You are losing sugar, which is the main problem here, is you're losing sugar in your urine. Why is that? Because if you go back to our kidney chapter, if you remember, we said in the proximal convoluted tubule, there is a reuptake of glucose, but there is also something called transport maximum that you cannot exceed. Well, obviously here you have too much sugar, and the too much sugar will exceed the transport maximum of the proximal convoluted tubule, and therefore sugar will start show up in the urine. Sugar, just like any soluble molecule, will start to have osmotic pressure of its own, picking up more water, missing the osmotic balance in your tubules, and therefore you have polyuria. You're losing a lot of water, you're losing sugar. That can result in infection. You are messing up your water balance, so you're ending up with dehydration, possibly dehydration. You are messing up the fat synthesis, so you have hypercholesterolemia, and you have deposition of fat in the blood vessels, and you have degeneration of blood vessels, which can result in diabetic retinopathy. It can result in peripheral nerve damage. It can result in a lot of situations where your terminal parts of your body, like your fingers, your toes, are not getting enough blood, and at the same time there is not much sensation there, so your immune system is compromised, so all of that can result in gangrene. Your kidneys can start failing. Diabetes is one of the main reasons, in addition to hypertension, for renal failure. So there are a lot of problems that unfortunately diabetes can result in. Okay, long-term consequences of diabetes: hypertension, renal failure, neuropathy, and both neuropathy and vascular degeneration can lead to gangrenes. Retinal degeneration can lead to blindness. That's one of the most important causes of blindness in Western society and developed world is diabetic retinopathy. If you have too much insulin, which can be the result of a person, as we said in the lecture, taking too much insulin than he should. You're supposed to take certain units and you double that. Let's say you are an older patient and you didn't remember how much you should take, and that can lead to too much insulin, which hides more than it should. And so now you're hiding too much energy. You shouldn't hide all that energy, so your brain starts lacking sugar, and that can result into diabetic coma because of that. Another problem that can cause insulin excess, you see how insulin is supposed to be secreted in response to high glucose and high amino acids, but what if the pancreatic cells are edgy? So you stimulate them a little bit, you're supposed to have appropriate response. But what if the response is exaggerated? So you stimulate them a little bit, and now you're having tons of insulin coming. We call that reactive hypoglycemia, which is an unfortunate situation because that also can lead to diabetic coma. Okay? All right. So we talked about the insulin, the lack of insulin. There is another hormone which is the anti-insulin. We need to talk about that. That is the glucagon. Glucagon is secreted by the alpha cells in the islets of the Langerhans. And it's a post-absorptive hormone. So, what it does, it liberates glucose. It liberates glucose, liberates fatty acids, right? So obviously it will be secreted in response to starvation. You missed a meal and now you have the glucagon. And what the glucagon does, it liberates some sugar for you to bridge the gap between the meals, right? Along with other hormones that are hyperglycemic. So, for example, growth hormone, for example, cortisol. All of these are hyperglycemic hormones that will allow you to bridge the gap. So when you're sleeping, you still can have some of the energy that you stored. Your body doesn't just completely collapse because you're not eating when you're sleeping, right? You're using the energy that you have stored all day, right? Okay. So there is an important fact here that glucagon is the anti-insulin, and that's why sometimes when we want to treat mild cases of diabetes, instead of working on the insulin, we would rather inhibit the glucagon, right? Because glucagon is the anti-insulin, right? So it makes the insulin more efficient when you're inhibiting the glucagon, right? An interesting fact here is that glucagon, which is secreted also in response to sympathetic stimulation to the pancreas, an interesting fact about it is that it also is secreted in response to high amino acid content. Wait a second. We also have your insulin being secreted in response to high amino acids. So are you telling me that both glucagon and the insulin, both of them, which are opposite to each other, are secreted in response to high amino acids? Yes. Why is that? Well, think of the situation, and I told you that in the lecture. You ate steak, nothing but steak, nothing but high protein, right? So imagine that situation. You are now stimulating only, hypothetically, the insulin. When you're stimulating the insulin and the insulin only, then you're hiding the sugar, right? Insulin hides and builds, right? Remember? Insulin hides and builds. You're hiding the sugar, but you don't have any sugar. You only have amino acids. So you end up hypoglycemic, and it can end up really affecting you negatively if you're only secreting insulin. But to balance that effect, when you're only having high amino acid content, what do? You also secrete glucagon, because glucagon will liberate some sugar, and that will balance the effect of insulin in hiding the sugar. Get the point? So keep that in mind, that both of them, insulin and glucagon, are secreted in response to high amino acids. And the reason for that is, in the absence of glucagon, if you eat only protein, if you only have amino acids and no sugar, and you're secreting a lot of insulin, you will end up with hypoglycemic shock. Make sense? Keep that in mind. Food for thought here. Okay. So what does the glucagon do in the carbohydrates? Glycogenolysis, and it gives you more sugar with gluconeogenesis, and also will stop glycogenesis. You don't want glycogenesis. You don't want glycogen. You want sugar. On the fat, you are breaking the fat and liberating ketone bodies and reduce the triglyceride synthesis. On the proteins, you will reduce protein synthesis, right? But it's not gonna degrade the muscles for you. It doesn't degrade the muscles. However, you reduce the protein synthesis because you would need that energy more, and therefore you have what we call gluconeogenesis, from the amino acids you will be making sugar, because remember, the glucagon is post-absorptive hormone. Post-absorptive hormone. Sounds good? Okay. So we said earlier that you want both to be secreted in response to high amino acids, but however, with glucose, with high glucose, you have less glucagon, high insulin. With low glucose, you have high glucagon and low insulin. So this is what we call the post-absorptive state. This is what we call the absorptive state. However, when it comes to amino acids, both of them are stimulated equally with high amino acids. So just keep that in mind. Other hormones that are associated with the metabolism, these are, for example, thyroid hormones. They are associated with growth and metabolism. Cortisol associated with growth and metabolism. Growth hormone associated with growth and metabolism. Steroids associated, anabolic steroids associated with growth and metabolism. So please don't think that the only hormones that are playing with the growth and metabolism and the fuel metabolism are insulin and glucagon. Sounds good? Awesome. So this was a review for the very last part of our endocrine lectures, which deals with the fuel metabolism. I hope you will find it useful for you during your review, and I will try to make later today another online lecture for the adrenal cortex hormones. If you have any question, message me, email me. We'll be more than happy to answer your questions. Have a great day.